West Orthopedics. All right, now we can maybe rewatch it and I'll see how I did. It's being recorded, it sounds like. So, Dr. Brian Forsyth gave an awesome lecture at the fellow. It's like they gave it was a pre, I would think I was the only one that went. It's only for the ortho sports fellows, but basically before we all started the year, end of July, fellows across the country came to this kind of overview little course of what fellowship is like, and he gave an incredible talk on this very topic. So I borrowed a lot of his slides, used a lot of his information, then kind of expanded on it using AI and picking the minds of all of my mentors and bosses, anyone really who I could chat with about these kind of things. So, elephant in the room is money here. This is an elephant I saw in the wild. I was doing a marathon in Kenya, and on the way to the campsite before the race, there was a nice little elephant I thought I might include here for a little bit of effect here. And this is then later on that year in India before I started medical school. I rode an elephant as well. So addressing the elephant in the room, money, is going to be really where the most of this talk will revolve around. So wealth planning, something that we all will have to do. It's a good problem to have, but there's something called a 4% rule. Basically, every 2.5 million of savings that you have, basically any 2.5 million that you accumulate as wealth by the time you hit 65, that generates approximately $100,000 per year. So if you want to, basically, if you want to live a 500,000 per year lifestyle, which is it's a pretty nice goal to have. You can live pretty comfortably with that. You want to aim for accumulating 12.5 million of 12.5 million of wealth overall. And similarly, same rule. If you want to live on 200,000 a year, that's pretty comfortable. Depending on your lifestyle, you want to aim for 5 million. So that's kind of a good goal, something to keep in mind as we keep working. And another thing important to keep in mind is you really don't want to leave this world with, if you're single, you don't want to leave the world with more than, it's subject to change, of course, but at this day and age, if you're approaching the end of your time, then you don't want to leave with more than 14 million, really, because even if you do want to create some generational wealth that you want to share with your kids, grandkids, you cannot, everything is tax-free for the first 14 million that you pass down, but beyond that, then you're taxed fairly heavily. So it would make more sense to spend the money while you can during your living years, rather than for example, if you're at 15 million, then I would, for me, I'd spend it down to 14, and then your kids can have your wealth tax-free then at 14, 27. If you're married, that gets a little bit more complicated depending on when the spouse dies and whatnot, but 14 beyond that is a little inefficient to pass with that. Missed time throughout all of our training for all the residents and non-op fellows. We all miss time. It's for us, Imagine and I, it's 5 years of residency, 1 year of fellowship, 10 years, and then for non-op fellows, 8 or 9 years as well. So it's either way significant investment as well. So definitely advocate for your worth, and don't feel bad about that. We have a very honorable profession, but we do need to be compensated for it as well. Another thing to think about is having kids. It can be very expensive to have kids, obviously, and it's projected the cost for raising a kid, if you start now, 300 grand to 322 grand, as Majid is experiencing. It gets very, very expensive, especially with young kids. So if you have 3 kids, that's $1 million. That's that you're going to lose from that wealth that we're trying to accumulate by the time we retire. And then also college in 2040, it's going to be anywhere from $200,000 to $500,000, depending on it's public or private. So it's something to keep in mind if you want to help your kids get through school as well. So if you have 3 kids going to college, you're kind of at one in the middle of the range there. It's going to be it'll be about $1 million there, and then if you have 3 kids, it's another $1 million there. So overall, it's $1 million and $1 million, $2 million if you have 3 kids. You should put aside or find a way to keep that nearby so that you can you can help your kids out if that's your goal. And 30 years of work, if we're doing really well and making 775,000 a year in Michigan after tax, that's gonna be $500,000. We lose a lot to the government. We'll get in if we have time briefly into how to avoid some of that. But if you save basically all of it, basically typed in AI, if you save all of it every year, 7% annual interest rate for 30 years, you'll end up with about 47 million. Obviously, you can't save it all. We got some expenses along the way, quite a few expenses, but that's kind of if you're doing well, making this number here, then you can essentially get up to that's the max you can get up to approximately if you don't have any other sources of income. So it's kind of a good goal number to keep in mind. And then that's kind of what I'm thinking about there is save it all, but then I want to drop it down to 14 million by the time I die, so that I don't have to pay the government and I can spend it all that I want to, and then save some for my eventual kids. One of the things, this is from Dr. Forsyth's talk, was he found a nice website. If you save $5,000 a month for 32 years, then you'll end up with $9 million. And $5,000 a month is fairly reasonable. In residency, I came close to even saving that much a month because I was very crafty and taking all the free food that the hospital had to offer, basically. So it is definitely possible when we have attending salaries. And but the difference is then there's a little bit of a different formula, so a different algorithm. But if you save 20,000 a month, now that's a little bit more challenging. If you've got kids, you can get up to 53 million, and that's higher than the 47 calculation that we had with that other algorithm there. But basically, you just the idea is you just exponentially keep generating more wealth the more you save earlier on, is kind of the idea there. As far as compensation goes, that's about where we're at now. $500,000 for orthopedics and procedural non-op sports medicine. I don't have the number for that, but I think it can approach that if you guys do a lot of injections in the office and see a lot of new patients and bill appropriately, as Dr. Keiko's taught us, with the higher level, and compensate yourself appropriately. Here's a compensation map. This is orthopedics. They have it on Doximity for every specialty. So you can check it for sure. I mean, I think I'm not sure if there's a non-op sports meds, but you could probably get the idea and extrapolate a little bit with probably PM&R, pain management perhaps, and they can, someone doing a lot of injections. And the red is where you can make a lot of money, basically in the center of the United States where no one wants to be. And then there's some pockets in the South, but basically if you're on the coast or in a city, you're going to be more in the blue, and so there's less money to be had. But you can click on the individual county on the Doximity map, and you can get a survey estimate of how much money you're expected to make based on who's currently practicing there. How long does your first job last for orthopedics? 50% of orthopedics is an interesting stat. Change jobs after 2 years, and then 70% after 5 years will change their jobs. And it's a little bit, obviously a little bit higher than I was expecting when I heard that stat. But you have to keep in mind where you're headed. If you're in Detroit, for example, where there are a lot of orthopedic surgeons, it could take you 5 years to get to a good spot. And so if you're not busy for 5 years, and then there's a 7% chance of moving on, then you have to build another practice after the 5 years as well. So you got to stay ahead of everything and cover a lot of football games and talk to a lot of PTs and ATCs to get busy early on. If you're in an unsaturated market like where I did residency in Erie, Pennsylvania, you can get busy pretty early on. 1 year is kind of when people were getting busier than they wanted to be even, but that's at the expense of living in Erie rather than living in a nicer, bigger city like Detroit. So the biggest reason surgeons move on apparently is geography is number one. So it makes sense to be in somewhere that you want to be, but obviously this is different for everyone. But geography trumps money, even culture. If there's a toxic culture, then you're gonna probably want to move on. But found that interesting. It is geography, so I'm definitely prioritizing that in my job search as well. But then there are obviously other things to consider if you're waiting for an academic position, or if things happen with the family, then obviously you're going to want to move on. So different job types. This kind of goes for op and non-op, but there's academic, private, as we knew, and then you can be hospital employed. And then from private and hospital employed, then you can still be involved in academics in some capacity. It doesn't exclude you from academics. And then there's also private academic model where there are places like Midwest Orthopedics at Rush that we talk about. I've talked about numerous times with the meniscal transplant guy that did Lonzo Ball's meniscal transplant and is also the Ball women's team doctor and there's the NBA team doctor. He's Midwest Orthopedic at Rush here, and his partner is the one that I modeled my lecture after. They are private practice, and but they are still heavily involved with the orthopedic powerhouse of Rush as well. So that's I guess the private demo. And then obviously Vail, Stedman, Rothman, Jefferson, big names as well. They're private practice, but still have fellows, residents, and everything in between. And then there's private equity, which is kind of basically like it's kind of a private, when private groups get bought out, private equity takes over, and they basically try to increase the value over a 5-year span. And physicians may not have as much say with what goes on as private, even though they may maintain some equity and get some of the incentive bonus there. Pros and cons of all of them. I'm not going to spend too much time on this slide because I guess we'll have these slides. I'll make them available if you want to go through it, but I'm not sure what everyone wants to talk about in terms of that. But Dr. Frush is a great resource for going through all that, actually, because he's been in private practice and academics and also hospital employed, all the above. So he can speak better about that. Recent trends, a lot more orthopedists are hospital based, and so that is kind of the trend. Private practice is becoming harder and harder to get to if that's your goal. You can basically make more money with what you kill with private practice. And hospital employed does have some RVU incentives, but it's not always easy to tap into them, and based on because you're not really controlling the workflow as well as every place is different. But if you're private practice, you can kind of, with maybe a surgery center, then you can kind of control the workflow and find a way to hit your goals for patient care and for numbers, doing surgery and all of that a little bit more easily. And private equity, you can retain some ownership, but basically you're kind of an employee now, and you kind of have to do what these businessmen are trying to do, and they do want to grow it, so everyone's on the same page there, but they may not have your best interest or the patient's best interest in mind as well. So it kind of adds a little bit of a complication. I'm going to kind of skip through this, but basically the moral of the story is you probably don't want to go into private practice if they are in the process of being bought out by private equity, because it's going to be a completely different environment when you finally get your job. And you also don't want, if you're looking to retire within the next 5 years, then you do not want the private equity to buy you out, because a lot of times they want you to stay for the full 5 years before they sell again. So you're probably going to want to exit and get your cash in your money before your hand is forced. You have to retire midway through, and then there might be some ramifications of that. So that's kind of where it comes into play for looking for a job or considering retirement. Basically the same things there. So moving on a little bit, and then we'll kind of circle back for certain things I found interesting about that. But interview, shifting gears actually quite a bit. The advice that Dr. Forsyth gave was be positive, interested, and prepared. And that's the obvious thing, but share your vision, be excited about it, and figure out exactly where your role is going to be. The biggest thing, though, is that you can, when one of the interviews in the process is that I took away was meet the youngest and the oldest physician. The youngest is the person that he's going to know exactly what you're going to go through, best comprehend what you're going to go through. And the oldest is going to be the one kind of calling the shots as well. So, and they've seen how the practice has evolved. So those are going to be good resources that you should seek out as well. And then when the contract comes, Then talk to your family mentors. Evaluate kind of what the situation is and kind of know your audience. I found this a little bit interesting. I haven't fully wrapped my head around this, what Dr. Forsyth said, but boomers are loyal to their companies. They started driving Ford, they're going to keep driving Ford. I guess Gen X, that age group, loyal to people, and I think, are mostly millennials here of residents and fellows. We're loyal to ideas, apparently. So keep that in mind when you're talking to the doctors from the group. Is, I think, what he was sort of getting at with that. I found that a little bit interesting, but figure out the practice type is important. Is it pyramid scheme where basically they are just kind of trying to get more docs to do their hard work for them, and then they're kind of getting all their money, or is it going to be more of a shared partnership where it's more equal and you're not really an indentured servant? Figure out exactly if you have a vote on the board of directors as well, even if you're not, if it's private practice and there's a 2-year buy-in. Figure out if you're able to maybe not have a vote right away, but sit in on the meetings and see what they're about before you actually buy in. With the second contact after the interview, make sure your support system's on board, basically, and then you can get the offer sheet and start to figure out if that works. Make sure that there's a good system in place for getting your patients. You don't want to just get the leftovers of whatever your senior colleagues don't want necessarily. Make sure that you've got a chance to actually hit your minimums and get a bonus as well, and figure out kind of if your private practice, what kind of insurances you're primarily going to be accepting. If you're going hospital employed, then talk to hospital leadership, and know that orthopedic surgeons, they generate, along with cardiologists and cardiovascular surgeons, the most hospital money for the hospital. So you're definitely, in the hospital especially, you're definitely making more money than you're going to be paid. That's part of the gig here, but just know that you will be providing a benefit. So you do hold a lot of the cards. So certain things that you should also keep in mind is, if you can, talk to someone who left the group and figure out why they left the group, because you don't want to be in that 70% at the 5 years where you do find yourself leaving. Ideally, you want to probably stay at the same place. It's a good setup. But another thing that I found that you should probably pay attention to is turnover time and for ORs, and staff retention for office non-fellows as well, I think is important. It speaks to the culture of the hospital, clinic, or surgery center. If the staff wants to stay, then you're going to have experienced staff that knows what they're doing, knows how to help you when you're just starting out. And it also says that it's probably a positive environment to work and a good location as well. And it really, I think, it tells a lot of the story about how your life is going to be. If there's rapid turnover, then there might be rapid turnover for you as well as the physician. So more business intricacies. Basically, just kind of don't be afraid to ask actually how you're going to get cases, and how many hoops you have to jump through to actually do what you were trained to do in residency and fellowship, and take care of patients. Referral sources is important to make sure that you get your business early on, especially if you're in a saturated environment. Taking ER call pretty much can get you to, you're going to get a lot of hip fractures probably if you're at a lower level trauma center, or you get maybe some back pain if you're non-op guys. Maybe not the most glamorous of things, but you'll learn get to know the emergency room doctors. You'll get to know the patients and their primary care doctors. So then when they have actual pathology that you're interested in treating, sports pathology, then or their other patients have that kind of then you might start to get some business from them. Covering high schools is critical. From everyone that I've spoken to, you can get a lot more business from high schools than with pro teams or colleges as well. And also your patient, a little interesting quote here, I think tells the story. every good interaction you have with a patient, they tell 10 people. So definitely want to be good to people. But if you have a bad interaction, they'll tell 10 times as many people. They'll tell 100 people. So obviously not perfect science, but I think there's some truth to that, people kind of internalize good things that happen to them. It's human nature, but bad things that happen to them, it is human nature to vent about it to as many people as possible. So you don't want to be on this side of it. And basically take care of them. Your patients, they take care of you. They'll send you more business. They'll return for more business. And someone said at the forum as well that I felt important to include is care about someone's back pain. Then to every back is attached 2 legs and two arms. So you can get some pretty good business from that as well. Another good quote from I think it was Dr. Forsyth that it takes 10 years to build a reputation. It takes a moment to ruin it. So basically similar to you have one bad encounter, then it can kind of it's really bad. It can kind of ruin everything that you built over 10 years. So try to avoid that. Obviously easier said than done, but basically the Coldplay concert situation is a perfect example of that. They're both successful, especially I think the male in that situation was pretty high up in the company, and now he's shows up on the big screen and everything is gone, his family and his job. So that's the most extreme example. Something to keep in mind is, and I wanted to stay on top of researching this kind of stuff and making this lecture, was that we are inherently not the best businessmen and women as doctors, because we were busy basically all of our adult life learning how to take care of patients, and then all of a sudden we're old. I'm 35. You guys, I think, are going to be a little bit younger, but in early 30s. But we're old basically, and then all of a sudden we have to magically figure out how to do the business side after we graduate from fellowship. So we kind of need to do a little bit of research outside, and keep in mind that there are people that are outside of medicine that can really help us out with this kind of business side a lot more, and so you can lean on them as well, but also not be taking advantage of these people outside of medicine. Hospital administration, for example, we may try to get you to take unpaid call, which my residency program, the junior docs, ran into an issue where they probably signed a bad contract where they weren't getting paid for call, and then they realized it too late, and they realized they were being a little bit exploited by the hospital, because they probably should have gotten a contract attorney as well, but they didn't keep that in mind. Other similar things can happen with that. As far as negotiating, when you do get the contract, you should find a way where you're winning and also your group is winning as well. That make it a win-win, and that way that's the best way to get any deal done, is when both sides are happy, and that's easier said than done. But get kind of figure out what your hospital group or private practice is looking for exactly, and see how you can work into that niche so that everyone can benefit. And something about, so yeah, they say get a contract attorney for sure. So I think that it's money well spent, but don't go after the base salary if you want to find a way to get a better contract, because that's a simple number that everyone understands, and it just sounds like you're greedy. But you can negotiate. The best way to go about it, if you want to get paid more, is negotiate a higher percentage of your collections, basically, for private practice. That proves that you are willing to work harder, and you don't care if you make a little bit less with the base salary, but you're willing to put in the extra work, and you want to get compensated. Then when you do go on to put in that extra work, and it's you can get paid proportional to what's the effort and the work that you put in, then they're more likely to accept that deal. So, for example, if you have collections of 30% versus 50%, 20% of 600,000, is about 120,000. So you can make 120,000 extra. Basically, if my math is right, basically just by getting a higher percentage. That's a little bit of an extreme example, but a higher percentage, you can, rather than going after a $120,000 increase in your base salary, will be more likely to accommodate that. That basically explains the same kind of example there, but because you are helping them out, cover their, if everything goes according to plan, cover their overhead as well, and you have your own overhead too. So asking for a higher base, especially at the beginning, because a lot of hospitals will lose money on you in the first year. So if you ask for more money at the beginning, then they might be a little annoyed, because it's really they want you for the long haul. That's where we start to make the hospital and private practice money. Another a trick that Dr. Forsyth brought up was break your bonus schedule into 6-month blocks, ideally, because if it's a full year, then you might not be able to cash in on the bonus, because there's about a 3-month delay in collections. So if there's a 3-month delay in collections, that first 6 months, you don't really have much of a chance to hit your bonus. But if it's months 7 to 12, then you will forego the bonus the first 6 months. Of the second 6 months of the year, you might actually have a chance to hit a bonus as well. That's a little bit of a nuanced thing, and some contract nuances. Figure out your buy-in. One of my friends that just signed, he interviewed at a place with for a private practice with a 7-year buy-in. So he had to wait 7 years basically before he could buy in. It's a little extremely ridiculous, but it was in the San Francisco area. Other things were appealing about it, but make sure it shouldn't be more really than 2 years, and that's a win-win. You can figure out if it's a good fit for you to buy in, and the practice can figure out if you're a good fit for them. So it shouldn't be more than, if you're doing private practice, shouldn't be more than 2 years, and kind of look at everything. And surgery center shares, that's a little bit complicated, but getting into that. But basically, we could get into that a little bit. That might get into the weeds a little bit, and I don't have a full understanding. But basically, they make sure you're getting a good deal with it. And Dr. Cook recently bought into a surgery center. If anyone runs into him at any point and is curious, he can give you more details on how they figure out the price and how he's getting his return. Billing is critical. I already mentioned Dr. Kakos is a great resource for that with anything in the office. He's the best resource in injections, making sure you're getting paid appropriately with ICD-10, and then 11, whenever. You said that was coming out soon, so I'm sure you'll be able to figure that out as well, and we can use you as hopefully a resource for life on that. But investing, we talked about that a little bit. Basically, you want to invest early and often, and you'll get some exponential return the earlier you start investing your money. And basically, don't really shouldn't, with our field, really shouldn't try to day trade or play the market. You should just buy low and never sell is kind of the advice that was given, and just keep growing the wealth, because the stock market is always going to go up if you buy a low cost index fund. And dollar cost average is also something that I do appreciate. Basically, you buy the dips over. No one can actually predict the dip, but if you, for example, have $10,000 to invest and you think we're approaching a dip, you invest $1,000 for 10 days consecutively, and one of those 10s will be the dip, but you're not basically putting all your eggs in one basket. They're kind of the same thing. I talked about that already. Ancillaries are important too. Keep in mind, you can make some good money on that. I tried to dig into that, find states that are friendly for ancillaries and which ones make the most money, but it's a little bit tricky to get some answers on. But x-rays are kind of the x-rays we should all have in our office, and as long as we document it appropriately, we can make some decent money on that. And then MRI and PT, OT is and DME. Those are a little bit tricky to figure out exactly how much money you can make sense. If it makes sense to makes sense to splurge on those. Basically, you can make a lot of money by consulting. That's another way to make money, build your wealth. And that is, I'm going to try to get through as many slides as possible over the next 5 minutes or so. So I'm going to speed through some of this stuff. The advice given by this guy is Dr. Forsyth was don't go too crazy getting into the side gigs the first 5 to 7 years in practice. You really want to make sure you figure out how to do your job effectively and take care of patients the first 5 to 7 years and even up to 10 years, because that's where, I mean, that's what we went to school for. We did all our training, and that's what we want to do, and that's really our calling, and that's really honestly the best way to reliably build wealth. And then you can take some risks once you do have some wealth. 45 to 55 are your peak years, and beyond that, during that time, you can start to take some chances and try to increase your wealth maybe a little bit more exponentially than linearly, because you already have a little bit of a floor of wealth there. Keep in mind that everything changes in healthcare every 6 months, and everything evolves. So everything might be changing by the time you actually get going in your practice. So be ready to evolve. I found a Google Scholar and PubMed actually had some. This was JAOS Yellow Journal. They got actually a really good article. I expanded on things a little bit more, but there's really a lot things written by physicians rather than just Google. You can find, or Reddit. You can find a ton more information. So I didn't even think about that until a few days ago and found a few extra things here. But it's important to note, I cherry picked a few things, that inflation adjusted salary for given the Medicare schedule has dropped 22% over the last 20 years. So that's not ideal. We're not alone. A lot of other great professions, lawyers, for example, and actors, they see theirs, in skilled trades, they see, in pharmacists see their salaries drop as well. So it's something to keep in mind. Some specialties weren't hit as hard. General surgery, it's with Obamacare and all that, the Affordable Care Act that changed the climate, but these guys are kind of lucky. But unfortunately, we saw some drops. But I guess President Obama didn't care about musculoskeletal issues we treat as much as someone's brain or their heart, unfortunately. But I see where they were coming from, but it's a little bit of a shame. Surgical centers, you can make a good money in that and get some really efficient patient care. Basically, was what they talked about. They're multi-specialty as well, and if you want to have multiple surgery centers, you have to perform at least 1/3 of your procedures at the surgery center. So you can really only have 2 surgery centers unless you have the perfectly even mix between 3 with 1/3, which is impossible, I would say. Surgery center, there are a few different ways. Not all are created equal. Some are hybrid sort of situations as well. And you can get some management experience as well that you can pay to help work on things. So basically, only 52% are fully physician-owned, then the rest are kind of hybrid, sort of hospital-owned as well. So if you're thinking about buying one, or even if you're doing your procedures in a surgery center as a non-op guy, then keep in mind what kind of surgery center it is. And hospitals can have greater than 50% ownership sometimes as well. Ancillary services can reduce overhead and X-ray, MRI. Building space is a little bit nuanced. You can either rent commercial real estate or a medical office building. And keep in mind, real quick, I'll try to get into tax offsetting, because $500,000 salary, for which a lot of us will be making around, it's only $315,000 post-tax. So the closer you can get that to $500,000, the better. So there's a fair amount of tax offsetting that you can do. And that's a little bit not enough time for all the things that you can do, but find a good accountant, then you can really find a way to find some loopholes and try to get closer to that 500,000 number. And there's tax loss harvesting, which is kind of interesting. You sell some investments and I'll find a way to sell them at a loss, and then you can find a way at the capital gains then to work that against your, basically negate your ordinary income, and you can find a way to not pay taxes on that. It's a little bit tricky, but there are legal ways to navigate the system, and also charitable ways as well. You can tax-free, you can donate money to charities that you believe in as well. Disability insurance, briefly, we get 40% discount basically as fellows, I believe. And so that could be for life depending on the program. So that's something that we should all probably look at. Maybe you guys are better about it than I was, but I'm behind probably on that, but I need to get that before the end of the year. And something that was brought up to me by one of my mentors is make sure that the insurance policy is specific for orthopedics for surgeries, because that way you can collect disability insurance if for example, your right hand, you lose a finger, then you can't do surgery anymore, but you can still see patients in the office. So you can make money seeing patients in the office, but then get paid out for basically the surgeries that you can't do by the disability insurance. So it's pretty similar for the ultrasound guided injections for non-op guys as well. It depends on a lot of things. Basically, your disability insurance costs and then side gigs. I talked about a little bit, a lot of different things you can do. I'll kind of skip through some take-home points, though, is prioritize your primary job for the first third of your career, and obviously take care of yourself and make sure you're happy and still in a good place to be doing your job. Embrace AI, because I think in our career, it's going to play at least some role. I think it's going to play a significant role in our taking care of patients. And if we don't, then embrace it, then I think other guys will, the young guys will, and they'll steal all our business. So in summary, I went over time a little bit, but it is ADHD Awareness Month, and in honor of ADHD Awareness Month, I created a little bit of a unorganized ADHD lecture, kind of just deep diving into things that I found interesting from Dr. Forsyth's lecture at the conference a few months ago. And I think hopefully it was definitely helpful for me to make and pick my mentors' minds a little bit on everything, and hopefully you guys got something out of that lightning lecture.
Nice job, Jeff. You were very ambitious there with this topic, because you could have had an hour lecture for 5 different things that you just outlined. It's very relevant, and you highlighted really the most important point. We just don't get enough talks in general as physicians on all of these subjects. And again, we literally, and I'm going to do my best to give some talks on this where you guys lead fellowship as well, really going into a deep dive. But I'm very happy you picked this topic. I'm happy you're exposing the residents, the med students that are on this call as well to it, because it's really incumbent on all of us to be responsible when it comes to this, even if it's not our primary focus. Obviously, our primary focus is physicians, but at the same time, we have a responsibility as well to not be taken advantage of. And so, I really could go and talk a lot about each one of these specific things, but I know we're probably in a little bit of a time crunch, but I promise we will have more lectures on this in the future. So I'll leave it at that for now. But if anyone else has comments for Jeff, feel free to chime in.
Yeah, nice topic. I agree. And it was really a fairly comprehensive overview. Important to do. When it comes to medical school and residency, the one thing we don't really do enough of is, in fellowship, I should say, is, we don't teach anyone how to teach. You go out into practice and then you teach residents and fellows and whatever else. We don't do a very good job of teaching people how to teach. And we don't do a good job of teaching the business side of medicine, unfortunately, throughout all the training. But it's an important thing to see, hopefully several times during training, this type of a lecture. I will say, when you're looking at your first contract, don't go for I would say, don't go for the big bucks, the ones that are, going to give you stipends during training, things of that nature, because they're always going to come with some strings attached and repayments, things of that nature. So I wouldn't necessarily be aiming for those. Find something that looks reasonable. As you guys are aware, 50% of you are going to leave within the first 2 weeks first 2 years of your initial contract. So I don't think I would stress a lot about that first contract, honestly. But the other thing is avoid private equity. Just stay away from private equity. never seen private equity be a great in medicine, and they are going to be in a lot of places where you go to look. And if there's private equity there, it means that the other surgeons or doctors have already sold out to some degree, and their practice situation is not going to be great because they did sell out. And so I try to avoid places like those, like the Core Institute, my old practice, which is now leaving the state of Michigan because they could not make money here. So anyhow, that's my advice.
Yeah, really good points, Dr. Frush, and thank you, Dr. Keikos, for the feedback and kind words. And we'll be sure to pick your mind over the next, both of your minds over the next 9 months.
Awesome. Thanks, Jeff. All right, I think we have Dr. Morasso, you're next. Is that correct?
Yeah, I'm happy to go now, or if Kyle wants to go first, that's.
Oh yeah, Kyle, I'll leave it up to you. Kyle, you want to go first? Do you want to go next?
Doesn't matter to me.
All right, go for it, Kyle.
Sounds good. Give me 1 second here. Set up. Share my screen. All right. Can everybody see that?
Yep.
So,
All right. So we will get started here. Let me just get this out of the way. All right. So I initially said that I wanted to do my topic on supplementation, both for, general population as well as the athletes. This is going to be more on common supplementations. Kind of got in the weeds there, and it was going to be a very, very long talk. So this might be a two-parter because it's something that I'm quite passionate about, something that I've been kind of on for a while, but there's always something new, especially these days. You get TikTok and Instagram influencers are always trying to tell people that they should be taking so-and-so supplement. And I feel like every day in clinic, someone asks me, oh, I'm taking this, should I be taking it? So that's why this lecture is I think important as well as useful. So this will be common supplementation used in the general population, clinical evidence, risks, and implications for practice. I have no disclosures other than that. I use some supplements and I might have a little bit of bias because I have used them before. So before we get started, we're going to play this little clip.
Funny. It's craziness. See, this is your problem. I can do this funny and beat myself in the belly. It's like an old devil and it's all safe.
All right. So, unlike Charlie Kelly, people don't use them for energy balls. And dietary supplements include a lot of things, including vitamins, minerals, herbal supplements, nutraceuticals. Over 50% of adults in 2024 reported regular supplement use in some form or way. The clinical relevance for this is there are potential benefits, lots of adverse side effects, lots of drug supplement interactions. People see them in the grocery store. They see them at CVS and Walgreens, and they assume because they can buy them over the counter that there's nothing bad can happen to them. And that's just not true. These things can be very clinically important and relevant in our day-to-day. And I think as sports medicine physicians, we tend to see this a lot because of, somebody sees something online and is like, hey, I want to try this. So the aim of this is to summarize our evidence, clinical use, and risk for common supplements taken by both patient and athletes. Like I said, the U.S. National Health and Nutrition Examination Survey from 2024 showed that greater than 50% use at least one supplement. Predictors for this are going to be those of higher education, female sex, and chronic disease. Why is this, different? Why is this different than regular day-to-day medications that we take? These are not regulated like drugs. They are regulated as food and thus not under the same scrutiny that the FDA would for most of these medications. They do not require pre-market approval for safety and efficacy, which means that there are a lot of risks in terms of contamination, variable potency, and mislabeling. This is not on this lecture, but I was reading Consumer Reports this morning of the top 15 most used protein powders, and almost half of them had much higher than our daily allowance of lead. And these were like common brands that everyone used, like common, like Optimum and like GNC brands. And a lot of them had these. So we should be able to we should document supplement use and counsel patients accordingly, because we might be the only ones that is actually paying attention to this. All right. So we'll start with multivitamins. Multivitamins are all over the place. Supplements, they contain both vitamins and minerals. There's everything from your Flintstones to your gummies to powders. There's so much variety. In 2024, 30% of adults were found to use a daily multivitamin. When asked why, main thing was nutritional insurance. So people feeling like their diet was not adequate enough nutritionally. Energy and immunity claims, thinking, hey, if I take these, I won't get a cold as much. Or disease prevention, thoughts that some of these substances can be potent and help with reducing chronic disease. But the evidence for them is not robust. There's no consistent evidence in reduction of all-cause mortality on multiple levels and multiple meta-analyses. Very convoluted evidence regarding cancer or cardiovascular disease prevention. The Physician Health Study 2 did show that there may be a small benefit for reducing any cause cancer, but then there have been other studies such as one out of JAMA 2023, which did not show any consistent benefit for cognitive or mortality outcomes. So very convoluted. I don't know why that reference thing is there. When do we need to use them? Or when are they efficacious? Special populations, so pregnancy, prenatal vitamins can be useful to reduce neural tube defects, but the best use of them is actually prior to conception. So people say, oh, we just got pregnant, we're going to take prenatal vitamins. Not as helpful, and it doesn't help because most people don't realize that they're pregnant until too many weeks after, okay? And when these are most important. And two, you want to build up those vitamins prior to conception to reduce the risk of neural tube defects. The elderly or the institutionalized patient populations that may have limited food intake in general, okay, or limited variety in foods, or don't have the gut health or integrity to actually absorb. All right, those who have restricted diets or malabsorption, that's going to be a common theme throughout this talk. Anybody with celiac disease, bariatric medications, okay? And those that are taking pretty common medications. So metformin is going to decrease vitamin B12. PPIs can reduce magnesium and vitamin B12. Is that, does that cause necessarily that people need to take a multivitamin? Probably not, and you probably need to be more specific in your supplementation. The safety and risk, the good news is that most over-the-counter multivitamins are generally safe at normal doses. It's when people start taking multiple, you think of the little kid that gets into the vitamin cabinet and thinks that the Flintstone gummies are, the Scooby-Doo snacks, and then they eat, and that's when we run into problems. But fat-soluble vitamins can accumulate. And the clinical use for these is quite limited. Minimal, I would say. And we always, and this is the big theme for this lecture, we should always encourage well-rounded diets or food-first approach. But that's not always, practical. People are going to use these. So I would counsel patients, if you're going to use them, use them once daily, once every other day. Make sure that you're limiting other supplementations that may compound some of these things, especially with the fat soluble vitamins. And really hone in and evaluate their diet to see, is this something that's actually useful for them? All right, vitamin D. So background for this: vitamin D, essential for bone and immune health. Deficiencies have been linked to osteoporosis, muscle weakness, immune dysregulation. In this one, there is quite a high prevalence of deficiency, approximately 40% of adults in studies that I was looking at in the past 5 years. Why? Limited dietary sources and poor sunlight exposure. I had the benefit of being down south in Virginia and North Carolina for the past 4 years. A lot of sun, easy to get outside, but working in medicine, so don't get to leave the hospital until it's dark out, which isn't, creating an optimum environment for vitamin D. We do have supplementation in things like milks, eggs, but it can be limited, especially in people that have poor diets. There's multiple forms. People say, hey, I'm taking vitamin D. What vitamin D are they actually taking? Okay, vitamin D2 is a plant-based. It's less potent, it's less bioavailable, it doesn't get absorbed as well compared to vitamin D3, which is more potent and has a longer half-life. There is one called calcifediol, but this is more for rapid correction and typically used in malabsorption or liver disease states. All right. When we're talking about things like bone health, multiple studies have shown that this, requiring vitamin D supplementation anywhere from Biscoff and Ferrari in 2012 to falls reduction 20 to 30%, and possibility of decreasing respiratory infection in deficient individuals. But where we don't see is any major effects of cardiovascular or cancer. Okay. Vital trial in 2019 showed nothing. And most of these studies show that the strongest evidence for these are not in patients that are at baseline have normal levels. So this is going to be our deficient patients only. So dosing in adults. It's based on, this is based on the Endocrine Society guidelines in 2024 for general adults, 600 to 1,000 international units per day. In older adults, typically their gut health and their bioavailability such as absorption is not as robust as in younger. So over the age of 70, they recommend a little bit of a higher dose, 800 to 2,000 international units per day. For people who are deficient, the typical dosing is 50,000 international units weekly for 6 to 8 weeks with a recheck at 3 months. I know in my previous hospital that I was at, that was at the orthopedics department, that was their dosing guidelines as well. For maintenance and people that are deficient only, this is where you're getting the 1,500 to 2,000 international units a day. Oh, excuse me. And then anybody who has obesity or malabsorption, you may need 2 to 3 times higher doses. The best one of this is, like I said, going to be the vitamin D3 or the cholecalciferol, excuse me. And sometimes you can get into weekly or monthly dosing, which has been shown to have similar efficacy and sometimes even better efficacy in maintaining healthy levels, because it's easier for patients to take them more on a monthly or weekly dosing. Makes it easier rather than having to take something every day. For how do we manage this? So recheck. So you find somebody who's deficient, you put them on, the 50,000 international units weekly for 6 to 8 weeks. You recheck at 3 months. Your goal is to maintain greater than 30 nanograms per milliliter. And then you get into the annual or biannual rechecks in your high-risk populations. So think like before, older adults in nursing homes, people with limited sun exposure. So pretty much anyone north of the Mason-Dixon line. Darker skin pigmentation, vegan diets, and specifically for medications, patients on anticonvulsants or glucocorticoids. Okay. And then for special populations, pregnancy, looking at 600 to 2,000 international units per day. Chronic kidney disease, this is where you can look into your calcitriol analogs. Obesity, up to 6,000 international units per day. And then malabsorption, either high doses or calcifediol. Toxicity is rare. The threshold level is typically greater than 150 nanograms per milliliter. Symptoms are going to be hypercalcemia, nephrolithiasis, confusion, nausea, those type of things, but very rare, especially up here. We deal a lot more with the deficient population. All right. So omega-3s or fatty acids in fish oil. So these supplements have a lot of uses in the body. So cardiovascular and circulatory changes, cell and metabolic function processes, nervous system function, and there's multiple types. So alpha-linolenic acid is a plant-based omega-3. This is usually found in flax seeds, walnuts, chia seeds. EPA is usually, and DHA are marine-based omega-3s found in things like fish, shrimp, shellfish, those types of things. People typically use these for multiple reasons. The main clinical use that we have is in hypertriglyceridemia. So patients who are in severe status of 500 milligrams per deciliter or higher, they will supplement this to reduce the risk of pancreatitis. It does this by increasing the breakdown of triglycerides through beta oxidation. Okay. Secondary prevention in patients with atherosclerotic disease who are also on statin therapies, but not seeing the lab level drops that would be expected. Okay. Questionable whether or not these have any anti-inflammatory properties, which may help with rheumatoid arthritis. The thought being that it reduces inflammation and oxidation by decreasing the adhesion between blood cells and like the walls of blood vessels to not allow for some of those inflammatory markers and stuff to actually adhere and proliferate. There's also there's some postulation that they might slightly lower blood pressure, although these studies are unclear or not proven. Multiple studies have looked at this, especially for the hypertriglyceridemia and cardiovascular disease. The Reduce It study showed that statin treated patients who have other cardiovascular risk factors such as diabetes and who do have persistent hypertriglyceridemia, those who receive up to 4 grams a day of EPA, so the eicosapentaenoic acid, actually reduced over 5 years, had reduction in cardiovascular death, non-fatal myocardial infarctions, non-fatal strokes, coronary revascularization, and like unstable angina by up to 25%, with a number needed to treat to being 21. So this has been implemented. The strength trial, though, showed that those that had a mixed, so EPA and DHA, did not have any changes or did not see any reduction in cardiovascular events. So most of the research right now indicates that EPA. So for dosing, cardiovascular risk reduction is usually 1 gram per day. Hypertriglyceridemia is 2 to 4. Like I said, that Reduce It study emphasized the 4 grams a day for the 25% reduction. Good thing about these supplements is there's minimal drug interactions. I did talk about the inflammation and the decreasing adhesion between blood cells, so it might increase the risk of bleeding. And there have been some studies that have also showed that arrhythmias are possible, so it can increase the risk of AFib. New research, this is going to be one of the big ones I think coming up in the upcoming years, is going to be how its effect on Alzheimer's and dementia. But these studies thus far do not show any nothing significant yet for reduction, but they may, and the thought is they may improve cognitive function, depression, and earlier mild disease for these things. I'll let you know that most of the over-the-counter fish supplements are typically mixed EPA and DHA. But if you're looking for something specific for a specific patient, you want the EPA. But most of the stuff you can get over the counter is going to be mixed, so take that into account. All right. So calcium. This one is probably the one that I think is one of the more important ones here, more because people think, oh, you need to drink milk, get your calcium. But calcium actually can affect a lot of basic things, especially with medications that are very common in these patient populations. So calcium itself is essential for bone mineralization, neuromuscular function, cell signaling. Its physiology shows it's a complex system with serum calcium being regulated by intestinal absorption, renal excretion, bone remodeling. There's mediators, PTH and vitamin D. Typically our indication or causes for hypocalcemia are going to be treatment and prevention of osteoporosis, PTH deficiency, vitamin D deficiency, kidney disease, malabsorption, medications, other things like, magnesium deficiency, liver disease, cancer, blood transfusion even can cause it acutely. But I think where we get into a lot of it is like medications. So like anticonvulsants, some antibiotics, and even chemotherapy drugs can lead to hypocalcemia. Clinical presentation for both. So hypoglycemia is going to be your neuromuscular irritability. Those are going to be kind of your oral paresthesias, cramps, tetany, seizures, prolonged QT, neuropsychiatric symptoms. For hyperglycemia, fatigue, constipation, polyuria, polydipsia, muscle weakness. Okay. Chronic hypocalcemia can lead to cataracts and basal ganglia calcifications. And even severe acute hypocalcemia can go with laryngeal spasms, bronchospasms, and I've already said cardiac arrhythmias. So dosing, the recommended intake of daily is 1,000 to 1,200 milligrams. Typically, there's only a max of 500 to 600 milligrams that's actually absorbed per dose. So if you have somebody that needs much higher, you have somebody who's very deficient, or you're worried about their bone health and you want them to take calcium, consider splitting them up. BID, there's multiple different types that can be taken. And these are the ones that actually have the elemental and different percentages of elemental calcium here in the table. So calcium carbonate is going to have the most, calcium citrate, gluconate, lactate, in terms of percent. All right. Yeah, I'll leave that here just for a second so you can read for the comments, but obviously the least expensive and the most commonly used one is calcium carbonate. And we'll talk about some of the other indications for which ones to take or when not to take right here. So there are risks of this supplementation, and for me, I think this one has the highest risk. So excessive intake, so 1,500 to 2,000 milligrams a day or greater. You have GI symptoms such as constipation, bloating, kidney stones, cardiovascular risks. So recent meta-analyses have shown that calcium supplementation may actually increase cardiovascular risk, such as MIs in postmenopausal women, and with bolus dosing, postmenopausal, especially those that are healthy. Okay, they have been shown to be approximately 8 to 20% increase in CVD and CAD in patients who are healthy, especially postmenopausal women, when taking calcium supplementation without vitamin D. Okay, there are also a few remote studies that I saw that showed that there's possibility of exacerbating prostate cancer. Right, but there's a lot of medication interactions as well. So this calcium can decrease absorption of thyroid hormone, bisphosphonates, quinolones, tetracyclines, PPIs and H2 blockers. They decrease the actual absorption of calcium carbonate. You can switch to calcium citrate to get a little bit better absorption. Can increase the toxicity or lead to less breakdown of digoxin, can reduce the efficacy of calcium channel blockers. Those patients that are taking thiazides, you'll decrease the renal calcium excretion, so you actually have a higher risk of hypercalcemia. Dietary fiber, which is very common, you do not absorb the calcium as well, and it can inhibit iron absorption. Okay, so lots of interaction. So, something as simple as, oh yeah, I take calcium, definitely something to talk more about with your patients. Vitamin C. So this one is somewhat the bane of my existence. It's a water soluble vitamin needed for collagen synthesis, hormone production, iron absorption, immune function. Deficiency leads to a breakdown of those processes, aka scurvy, which leads to bleeding, bruising, and poor wound healing. Clinical use, I think it's minimal, and that's my own bias. But treatment of scurvy, there are that's the only true clinical indication that we have. There have been studies that show that it may reduce the duration and severity of respiratory infections, especially those that have like a low baseline vitamin C, or where I think we might have a little bit more clinical indications, those who have high metabolic demand. So those who are critically ill, athletes, the elderly, although it has been shown that high dose like IV vitamin C has not helped with things like sepsis and COVID-19. The thought being that vitamin C can modulate inflammation and like your immune response, which may reduce the length of respiratory infections, as well as autoimmune, hematological disease, and chronic disease. Typical dosing is 75 to 200 milligrams per day. That's generally sufficient in healthy adults. And then if you need to optimize 200 milligrams per day, if you're treating scurvy, 100 to 500 milligrams, but most of us aren't going to do that. Risks, fairly minimal because it's a water soluble. So high doses may cause GI upset like nausea, diarrhea, and increased risk of kidney stones, and it can possibly interact with chemotherapy. The reason why I kind of stated what I said before is vitamin C is in a lot of things. So if you eat anything that's relatively colorful, you're getting your percent of daily value very easily. Plus, almost all supplementation multivitamins have it in there as well. But we'll discuss foods for these things later. Iron. So iron is very common. It's essential for a very common supplementation. It's essential for oxygen transport, energy production, DNA synthesis, and cell metabolism. This one is quite common in terms of deficiency, 14 to 15% of US adults. Special populations that have been shown to be more iron deficient are children, premenopausal women, pregnant women, and then iron deficiency anemia is less common. So 2 to 5% of US adults, up to 13% of reproductive age women. Absorption, so iron absorption occurs in the duodenum and the proximal jejunum, but only 10% is actually absorbed. This can be enhanced by taking it with vitamin C, which we'll talk about with a little bit, but there are a lot of things that can block or stop the absorption of iron, things like calcium, even very common things like tea, coffee, PPIs and H2 blockers. They reduce the acidity, the gastric acidity, which can have a downstream effect on absorption. Dosing, so oral iron, we typically go 100 to 200 milligrams a day. There's been some new research on the actual dosing frequency. So there's been a change from the daily to every other day dosing with similar outcomes. So iron absorption is tightly regulated by a protein called hepcidin, which is a hepatic hormone that rises acutely after oral iron intake. Which actually reduces absorption of the iron of other supplemental iron for 24 to 48 hours. So a lot of guidelines now are being changed to a more every other day dose. Structure, there's multiple different types, similar to previous supplements that we talked about, such as ferrous sulfate, ferrous gluconate, ferrous fumarate. They all do pretty well in terms of compatibility. IV iron, we don't typically deal with. That's more of a hospital thing, but this is going to be reserved for patients with intolerance, malabsorption, rapid depletion, things ferric carboxymaltose and ferric deoxymaltose. You can do quite high doses for your infusions. For supplementation, we typically see or start to see improvements in levels after about a month. But you can continue for 3 to 6 months without much issue until you start to see good lab levels returning. Risk of supplementation. So the main one is going to be your GI side effects, which is why a lot of times we're switching more to every other day dosing. So nausea, constipation, diarrhea, vomiting, the promotion of like gut inflammation. Okay, especially in patients with like IBD, be on the lookout for this. Okay, and every other day dosing has been shown to be efficacious for patients like who have CKD, IBD, and pregnancy. All right. Okay. Vitamin B12. Vitamin B12 is a cofactor in the synthesis of DNA, red blood cell formation of myelin. The epidemiology is in risk factors for this. It's fairly prevalent, up to 2 to 3% of US adults. This is going to be seen a lot in older adults, vegans, those who have malabsorptive disease such as IBD and celiacs, post-bariatric, medications that can inhibit or reduce absorption, metformin and PPIs. Usually your clinical presentation is going to be fatigue, paresthesias, cognitive changes. In terms of absorption, the reason why a lot of these malabsorption diseases cause issues are like post-bariatric surgery is because the stomach acids, HCl and pepsin, get released in the stomach, which actually release the vitamin B12 from food. So this is coming from sources like meat, eggs, dairy products, which is going to bind to intrinsic factor that gets released by the parietal cells, and then downstream it gets absorbed into the terminal ileum and transported throughout the body via transcobalamin. So anything that's going to inhibit that, so age-related malabsorption, strict vegan diets, you're not going to be getting that. Vitamin B12, GI disorders, you're going to have less in the body to actually help her out. Diagnosis and assessment, so serum levels. So deficiency is considered to be less than 160. Low to borderline is 200 to 300. Normal is 160 to 950, depending on your lab. Some labs are a little bit different. We don't just jump to vitamin B12 supplementation after. We look at methylmalonic acid and homocysteine. And if these are elevated, confirms usually vitamin B12 deficiency. Treatment for this: oral 1,000 to 2,000 grams daily, weekly for maintenance once you kind of got back up to levels. And we don't do too much with parenteral, but IM 1,000 to 4 to 8 weeks, then monthly for maintenance. There's no difference in terms of efficacy in terms of oral versus parenteral. Usually it's just orals for patient preference, and then parenterals for like severe deficiency or those having like neurologic symptoms or known malabsorption issues. Magnesium. Magnesium is the most abundant intracellular cation and involved in over 600 enzymatic reactions, including energy metabolism, protein synthesis, neuromuscular function. It's very highly regulated by intestinal absorption and renal excretion. Normal levels in the body are going to be 0.7 to 1 millimoles per liter. Most people don't take it. You know, they don't say, oh, hey, doc, I'm taking this because of all these enzymatic reactions. Usually, especially in the influencer space, it's used for things like migraines, metabolic disorders, muscle cramps and spasms, and sleep quality. Migraines, oral magnesium has been actually, if you take 400 to 600 milligrams per day, can reduce the frequency and intensity of migraines. Some studies coming out of the VA have showed up to 2.6 migraine headaches in reduction per month after 12 weeks. This is grade C evidence. In metabolic syndromes, especially those with obesity, type 2 diabetes, it may improve blood pressure and glycemic control, but studies on this are limited. And then for muscle cramps and sleep quality, limited in terms of if it's actually efficacious. So nocturnal leg cramps is one that people will come to you and ask about, but it's hasn't been shown to be superior to any placebo. Sleep quality, it may reduce the sleep onset latency by up to like 17 minutes in some studies, but it doesn't change with like overall sleep time and treatment of insomnia. And we get to this. There are so many different types. So magnesium citrate, you know what this is typically used for. It's typically used for laxative especially prior to colonoscopies. Magnesium glycinate, this one is highly bioavailable and more gentle on the stomach, and you can read the rest. But there are so many different ones out there. I was actually at a store yesterday, saw about half of these, and so yeah. Dosing, like typically daily dosing is 200 to 400 of elemental magnesium. The main risks for this are going to be diarrhea and hypermagnesemia. Hypermagnesemia, think more your chronic kidney patients, because this is renally cleared, can lead to hypotension, bradycardia, some arrhythmias, and if it's really bad, cardiac arrest. I didn't put anything in here about its like use in terms of like acute hospital, torsade de pointe, all that kind of stuff, because we're going to be seeing these more on an outpatient basis. Vitamin E, it's a fat-soluble antioxidant which helps protect cell membranes from oxidative damage, immune function, prevents LDL oxidation, has a very limited supplement use in terms of oral, because it's in pretty abundant in modern diets. It's in nuts, seeds, vegetable oils. Anybody who has like a malabsorptive syndrome, possibly non-alcoholic fatty liver disease. It's been shown to improve the actual like histological view in non-diabetic patients with non-alcoholic fatty liver disease. But most of the time, the supplementation for these is going to be managed by a specialist if you have someone that's like acute deficient of vitamin E. But dosing, only 15 milligrams daily. If you have anyone who's truly deficient, 100 to 400 international units per day, and you can increase that with malabsorption. This one has some significant side effects. So it increased the risk of bleeding, and high dose chronic use of over 400 international units a day can actually be associated with increased mortality risk secondary to bleeding, because it inhibits platelet aggregation. So definitely patients who are taking other anticoagulants, antiplatelets, counsel them on their dosing for this, because it can actually cause increased risk of bleeding. And then to kind of rapid fire some of these other ones, there are hundreds of herbals and botanicals that can come up. Things like turmeric, echinacea, ginkgo, St. John's wort, clove. There's so many out there that people will try just because they see something online, or they, a lot of times these people are grasping at straws for things to help them. So turmeric, we think of, oh no, that's just a part of, curries and foods and stuff. No, it's some people actually do take it, and it's been shown to have anti-inflammatory effects, known antioxidant and modulation via cytokines, but it's poorly bioavailable. So you need to take it with black pepper extract. The curcumin extract, curcumin is the main active ingredient. If you're going to actually supplement with this, 500 to 2,000 milligrams per day. Turmeric root powder, 1 to 3 grams per day. And to enhance it, you take it with cracked black pepper or black pepper extract. There has been shown to be moderate evidence for inflammation and pain control and osteoarthritis, minimal evidence for rheumatoid arthritis and dyslipidemia. Potential side effects: GI upset, gallbladder issues. So anybody who's had their gallbladder taken out, definitely counsel them to not take this. Increased bleeding risk, poor iron absorption. Excuse me. Echinacea is a plant with active components of alkamides, cafeteric acid, derivatives. It's supposed to help immune system. So think people with like upper respiratory infections, they take things like teas. The most effective aspect or effective form of this is going to be the true extract, which you can take 300 to 500 milligrams 2 to 3 times per day. This upper respiratory infection can actually reduce it by 0.5 to 1.5 days in total time for things like colds, but does not have anything to do with prevention. And this can interact with some immunosuppressants, especially corticosteroid and the cyclosporins. So ginkgo, the active ingredients are flavoglycosides and terpenoids. These have vasoregulatory effects, neuroprotective effects, and effects on platelet activating factor. If you get the true extract, the dosing is 120 to 240 milligrams a day. BID. So split that dose, but typically most of the time people do this in like teas or tinctures, those types of things. This has been shown and has some good evidence that it helps with mild to moderate impairment and cognitive impairment and dementia as people get older, as well as in peripheral artery disease due to the platelet activating factor. It can help with not having clotting. So main thing for this is going to be bleeding due to that platelet activating factor. Seizures, it can lower the threshold for seizures. So look out for patients that are taking this that have had that or are taking seizure medications, and GI upset. St. John's wort, active ingredients are hypericin and hyperforin. This one resembles SSRIs, so has been shown to be quite useful in treatment of mild to moderate depression, and it inhibits neurotransmitter reuptake. Does have some other use as well. It modulates the HPA axis, some anti-inflammatory processes. Extract is going to be 300 milligrams PO daily. There are extended release capsules that you can take. Typically, we treat these or use these just like SSRIs. So if people are taking them, just remind them that they need to taper. The side effects for them, though, is it's a potent CYP2A4 inducer. So things like warfarin or oral contraceptives. Definitely counsel patients to not be taking this herbal supplement. And because it has similar structure in terms of SSRIs, you have an increased risk of serotonin syndrome with other medications like SSRIs or MAOIs. So there's a lot in terms of what people can use, and this is a very limited list. So what do I use? I take vitamin D3. I use 2,000 international units every other day. The brand is Pure Encapsulation, fish oil, magnesium glycinate, and every once in a while, multivitamin. That's typically on the days where, either I've been traveling or I haven't been eating a lot, or, I can't get something down because I've been vomiting all day, just to get a little bit of nutrition in every once in a while. But clinical pearls, I think it's important. We ask every patient about supplement use, especially because it's very prevalent, and make sure we verify evidence before recommending, and not just verify, but recognize and discuss with our patients what other medications and stuff they're taking, especially other supplements. Focus more on patients that have documented deficiencies rather than maintenance dosing. Beware of high dose antioxidants or fat soluble vitamins. I actually had a buddy in medical school that gave himself vitamin A toxicity from supplementation. Document and monitor for interactions. Most vitamins and minerals show only benefit in deficiency states. Routine multivitamin use offers minimal prevention and benefit. So you're essentially creating very expensive P. Some supplements, think like vitamin E, calcium, they may actually cause harm in excess. And then the focus should always be on a diet first, or a food first approach. I put these links in here, but I'll back out of this and just kind of go to these. There are lots of reputable sources out there that can discuss with patients, hey, this is what this is for. These are the foods that you can get these out of. And if you kind of integrate some of these things into your diet, you shouldn't need to spend money or risk on supplementation. And the National Institutes of Health has a nutrition page, which goes over hundreds of different supplements that are out there, how they interact, when to take them, how to take them. So don't be afraid to kind of use some of these reputable sources to help in managing your patients, because people are going to look and find information wherever. So, and that is my presentation. Any questions? Anyone want to talk about anything? Shoot.
Yeah, nice job, Kyle. You guys both picked excellent topics, because again, you could spend hours talking about what you guys just talked about. But supplements, obviously a very hot topic in orthopedics. You hit the nail on the head there at the end, right? And I think for those that have worked with me have known my mantra, so to speak. And right, they're called supplements for a reason. They're supposed to be used in addition to what you're primarily doing, which is food. And the vast majority of supplements that we ingest are much better absorbed. They're more bioavailable, and there's more synergistic effect if you can get it through dietary sources than through supplementation. Now, with that being said, you highlighted a lot of the critical points there on, especially here in the Midwest, right? As the sun goes down here and daylight savings creeps up here on November 2nd, we're going to spend less and less time in the sun. So I think almost everyone in Michigan should be taking a vitamin D supplement in the winter time, at least when the sun is not out. Just a couple of things with calcium. Just got to be mindful of supplementing calcium for kind of postmenopausal women. There's been some link with cardiac issues there as well if you're taking a dietary supplement. I know you mentioned that. Iron, another one that gets brought up, back when I was a resident, and it was not that long ago, we used to do it 3 times a day. They were getting ferrous sulfate 325 3 times a day, but we are finding that it is actually kind of inflammatory, pro-inflammatory. So I know we've scaled back because of the GI side effects and other things, but there's also some kind of deleterious long-term effects with iron supplementation as well. So really important that when you recommend it, that it's being recommended appropriately and it's being followed closely with kind of the minimum dose possible there. I think the other one, which I don't think you really commented too much on there, obviously you talked about protein, which is so crucial too, because the study that you referenced there with the amount of lead in all these products, or the slide that you mentioned, that it's so unfortunate because you just don't the lack of regulation really limits the accuracy of what you're getting. We all know that, and sometimes to translate that to our patients is really important. That's why I always tell them, and to make sure you're getting third-party tested somehow. At least that adds an extra layer of protection, and even then, it's not giving you full protection that what you're getting and what it says on the bottle is actually what you're taking and what you're ingesting. And so how that interacts with your other health issues, other medicines that you're taking, can really wreak havoc without, especially if you're not asking them or bringing that up. Now, I don't think you really mentioned creatine. Did I miss that
I
part?
did not. Nope. So that was going to be probably part 2 because there just wasn't enough time to get through everything.
Then
So.
we'll save that for later. But yeah, other than that, I mean, it's a very comprehensive approach. The only other thing that I would add is the resources that you included at the end were excellent. From a more kind of scientific, the examine.com does a very good job of going through the data there for pretty much any supplement, and not just supplement, I would say any other, even peptides, which are very big in the longevity space right now as well. And then obviously even some of the anabolic stuff people are taking. Examine.com does a really good job of going over the pros, cons with all that. So it's just another resource for people to have.
I will take a look.
Perfect. Any other comments for Kyle?
I was going to ask him, like, so what do you take after all this? And that was perfect. He added it in the last slide.
Awesome. Well, thanks, Kyle. I appreciate it. But great talks today, guys. These are really good topics, and we'll springboard and piggyback off these for future ones in the fellowship year there. So I'm happy you guys were able to come and share those talks, and you guys enjoy the rest of your evening.
Thanks, everybody. Have a good night.
That was good. Thank you.
Sounds good. Thank you, guys.
Bye.